Can you see the screen? Oh, there it goes. It was just delayed. Okay. All right. We're going to start our orthopedics lecture. This is a somewhat deep chapter because it does encompass the entirety of the body because it doesn't break it down into systems like we've been doing. So it's the entire skeletal system as far as injuries go. But we're going to try to make it as simple and painless as possible. Okay. So we're going to look at how we will assess, package, and transport these patients. We're going to look at some of our open and closed fractures, which we've already talked about a little bit. Dislocations and amputations. This gets juicy. And we're going to look at some of the patho of our upper and lower extremities orthopedic traumas with these fractures, dislocations, strains, and sprains. We're going to also look at pelvic fractures, replantation, and compartment syndrome, which we have talked about just a little bit already. And we're going to apply what we know to other medical systems into the treatment into our orthopedic emergencies. Now, there is such a thing as non-traumatic fractures. It happens with people that have what is called osteogenia imperfecta. They have bone issues. Have you seen that movie Unbreakable? I think that's the name of Unbreakable with Samuel L. Jackson and Lord, what's the dude that was married to Demi Moore? You know who I'm talking about. He played on Die Hard. Yeah, but it's the dude that played on Die Hard. What's his name? Oh my God. I can't remember his name, but they were in the movie, and the guy that was married to Demi Moore was a superhero. He didn't realize he was, but he could not be hurt. But then Samuel L. Jackson, who was his counterpart, the wind could blow and he would break a bone. He was called Mr. Glass or Dr. Glass or something to that effect. So that's how some people can have non-traumatic fractures. I forget it's a little boy on Facebook. He had some kind of growth issue. His name is Byron, little black kid, cute little boy. His limbs are deformed. He can't walk. But if he tries to stand up, potentially, his bones will break. And I think he has that osteogenius imperfecta. I may not be saying the word right, but it is. Most people that I know are born with it. I've not seen very many people that have it live long, but it's a non-traumatic fracture they can get just from standing up, picking up a cup, walking, thinking. Yeah. So we're going to look at some of this stuff, okay? Now, musculoskeletal injuries are easy to identify because they cause pain or swelling and deformity. Now, just because it's an injury does not necessarily mean that it's going to swell or be deformed. It can just cause pain or swell or be deformed or have a combination of the three. It's not fatal, because if it was, there would be no people left. but it can result in either short-term or long-term disability because you need your muscles and your skeletal system to do everything in life. Okay. It says never forget to assess airway, breathing, circulation, disability, and exposure. That is a given on any situation. Okay. Now, your musculoskeletal system is what gives you movement and shape. Muscles are connected to the bones by tendons. The bones themselves help create blood cells that we need to live, both white and red. Your muscles, because some of this is getting back to anatomy, depending on location, are specialized. Cardiac cells are only found in the heart. Smooth muscle cells are found throughout the body. And other types of muscle cells are found throughout the body in different areas. And we use those to exert force on different things. And that force creates movement. We've already said it helps maintain your posture to sit or stand. It keeps you upright. The less muscle tone you have, the more slumped your posture. Hey. And contractions require energy. So we have to fuel these muscles with glucose that is derived from food. They need oxygen to move about. When they don't have enough oxygen, it produces lactic acid. And we went through that when we were talking about our pathway with our Krebs cycle and things such as that. I already sent you the link, baby, so just. Now, muscles have nerves. Skeletal muscles are innervated by a somatic motor neuron. It looks more like a sheath with a hand splayed at the end. That is how your nerves look. At the end of each finger, you have sites where they receive and transmit impulses from other muscles and other parts of your body. Okay. Recruitment to generate a more forceful contraction, it needs more neurons to excite that muscle. Does that make sense? When you're sitting still, if you're using your hand as an example, you may only need one neuron to be excited. Versus when you move your fingers, like you just did, you need all of them to be receptive. Okay. Skeletal muscles have arteries, veins, and nerves. Arteries bring oxygenated blood to it. Veins take the deoxygenated blood away. And the nerves control movement. This is just a picture of your arteries and veins in various parts of your body. What do you notice about this that you can see in this picture? You may be able to blow it up. I'm not sure how your computer works. If you look in the one on the upper part in the arm, what do you see as the largest vessel up there? Mm-hmm. What do you think that comes from? Yeah. But think about location. What's the largest vessel up in that area? In the upper part of your body. Hmm? Hmm. Then look at the bottom part of your picture of the thigh and the hip. Hmm. Which is labeled on here as your abdominal aorta. That is nothing but your inferior vena cava. It travels the length and breadth of your body. Think about it, branches off. Creates your aortic, your subclavians, your brachial arteries, your abdominal aorta, your iliac arteries. So it travels the length of your body. Okay. Now, when we look into the skeleton, and this is getting back into your anatomy, it's divided into two parts. Oh, that's cute. Look. You have your axial skeleton, which is the central part of your body, and your appendicular skeleton, which is divided into your pectoral girdle, pelvic girdle, and bones of your arms and your legs. So your axial is just basically your chest. The appendicular is everything else. How many bones do you have in your body? Yes. You will see that again. That is a National Registry question. You will find how many bones are in your body. Now, your upper extremity goes from your shoulder to your finger. That includes your upper arm, your elbow, and your forearm. Your radius and ulna make up the forearm. Your radius, which is by your thumb, is where you assess your pulse. That's one way you can remember which bone is where. Your radius is where you assess your pulse, is by your thumb. Your ulna is by your pinky. Usually, because these bones are right next to each other and they run parallel, if one is broken, the other is broken. Now, are there times where one can be broken, the other is not? Yes, stuff happens. People are amazing and things happen. Okay? Look at the bones of your hand. You got three sets. You got your wrist, which are your carpals, the middle hand bones, which are your metacarpals, and then your phalanges or your digits, which are fingers, which you actually have 4 fingers and a thumb, technically. Hey. Now, your pelvis supports all your weight. Your pelvis and your thighs and your legs. So in your pelvis, it protects certain organs, primarily your reproductive organs and your bladder and your rectum. Okay. So when you look at your iliac, you remember we were talking about that yesterday? On the genital urinary, yeah, how it kind of flips out. I'll see if I can find a video since we're in this part of the body. Let's see if we can find one. I thought that was kind of cool when I saw that. I didn't know it did that. Mm-hmm. Okay. Let's see what we can find. This may show it. Let's find out.
Hi everyone, this is Kim Botany, the fitness doula, and I'm going to shoot a quick video to talk a little bit about the pelvic inlet and the pelvic outlet and how you can position yourself during your labor and your birth to help optimize the space for the baby to move into and out of the pelvis. So I have a pelvis model here, and I'm going to point out the 2 points that I'm talking about. So the pelvic outlet is the space between the sits bones, the pubic bone, the pubic joint, and your coccyx or your tailbone here. So this is the outlet where the baby crowns and comes out into the world. The inlet is the top part here when the baby is starting to move into the pelvis and down and eventually out of the outlet here. So in early labor, that's when we want to increase the space in the inlet. And what I want you to pay attention to here is the sacrum. And this pelvis, the movements that I show you are going to be exaggerated, but it'll give you an idea of what's happening in your own body. So the sacrum here has the ability to nutate and counter-nutate, and that also affects the outlet here. So if I hold it this way, so nutate and counter-nutate. As we're trying to increase the space in the inlet, so in early stage labor, we actually would want to be in positions that almost tuck our tailbone under, and you can see how that increases the space here. So if you're sitting on a stability ball, which is actually what I'm on right now, positions where you would be rocking, so I've got other videos that I talk about rocking and stretching on the ball and also tucking your bum under, so kind of doing pelvic tilts, can be very helpful in terms of increasing that space here in the inlet as we're trying to allow the baby to move into our pelvis. When it's time to push, so as the baby has moved down, their head is getting ready to crown, that's when we want to increase the space here in the outlet. So you can see that if I was in a position where my tailbone was tucked, that space is actually reduced. If I can move into positions where my sacrum can get out of the way, it increases that space, as you can see. So there's decrease in space and an increase. And again, these are exaggerated movements, but in early labor, we want to create space in the inlet. In the second stage, when we're actually pushing, we want to increase space in the outlet, and that will help make for an easier transition and birth for our babe. The other thing to note too is we do have other bony prominences in the pelvis as well, that sometimes, depending on the baby's position, like their head and everything, sometimes they can kind of bump into those. So the more we can keep freedom of movement in our pelvis, the less likely it is for the babe to kind of find something and feel like they would get stuck there. So any asymmetrical movements that allow you to twist and rotate, I've got other videos where I show you different leg movements where you extend your legs out to the side. Any of those type of movements will also help with the asymmetries in the pelvis and help move things so that the babe can kind of, navigate its way down without reaching points of tension or bony prominences that might kind of act as a sticking point for them. So inlet, outlet, and asymmetries in our pelvis are all really important to pay attention to in labor and in our birth, and also something to keep in mind when we're training. So we want to find movements that allow us to practice the pelvic tilting and untilting, and the side-to-side movements, and also the asymmetrical movements that will help keep the muscles around the pelvis loose and limber and free of tension. So
All right. So now you got to see how what I was telling you about how it, rock backward during childbirth. Yeah, it's a little stressful and traumatic. That's part of some of the labor pains I think that some women feel. We just didn't know what it physically looked like. All right. So now we know what some part of our pelvis is protecting. Now, each lower extremity consists of a thigh, a leg, and a foot. In a normal world, we each have one. They should be symmetrical and be the same length. Now, do we have situations where you may have one strong leg and one weak one? Like in a scary movie, he had the strong arm. Yeah, that does happen. But typically it should be symmetrical. And your foot, just like your hands and your wrist, have three sets of bones. You got your tarsals, which are your ankle bones, your metatarsals, which are the bones of the plantar side of your foot, and then you have your phalanges, which are your toes. Which some people, they have long skinny feet like I do. Your toes may look like fingers on some people's hands. But the thing is to keep them looking cute. Now, a joint is formed wherever two bones come in contact with each other. Okay, now the question is, what kind of joint is it going to be? If it only swings one way, it's a hinge joint. You may have some that have a circular motion, like your shoulder, and some that don't move at all, like your skull. Joint may let you flex, extend, abduct, which is away from the body, adduct, which is to rotate, circumduct, pronate, and supinate. Do we know what those things are? Hmm? Goes around. Yeah. Okay, that could be also be considered to a certain amount of rotation, anything that spins. Pronate rocks out. Supinate. No, yeah, pronate is in, supinate is out. Like some people, and I found this out when you go to, it's a shoe store. It's something to running something. All they do is sneakers. They will map out your foot and video record you walking on a treadmill so you can see how your gait works, whether you pronate, supinate, and they map out each foot, which is kind of cool. And they will make you insoles for your shoes based on your feet. So you take out the ones that normally come with a Nike, stick in the ones they mapped out for your feet, and it should support your foot based on where your instep and all that good stuff is, which was kind of cool. So it's called the running something. I can give you the name of it. I don't know the name of that store, but it's pretty cool. It's where I had to find my hocus. Road Runner. I think that's the name of it. Come on. I'm telling the phone to come here, and it's right here in my hand. I want to say it's Road Runner Sports. Yes. It is Road Runner Sports. So they have locations, some are everywhere. I don't know where all of them are, but that's where they map it out. If you decide to buy the insoles, I want to say they're like $80, but they give you like mad discounts when you go in there and you get some stuff. Now, bones are classified based on their shape. Long bones are longer than they are wide. Short bones are wide as they are long. Flat bones are thin, broad bones, which are like your skull bones. Your irregular bones have complex shapes that are designed to perform specific functions, like your wrists and your ankles. Sesamoid bones or round bones are generally found in tendons. Okay. Like a long bone normally has a head and an end. Okay. They have a growth plate, which is usually around the head, and that's usually called a physis in children. They have a hyaline cartilage cap, especially if they articulate into a joint. And the diaphysis is the actual shaft of the bone. And the epiphysis is the termination of that to another joint. So in this case, you are looking at a femur, looks like, just in this picture. Your tendons connect your skeletal muscle to bone. Ligaments connect bone to bone. I don't know how to make you remember that. It's something I jack up on a regular basis. Yeah, but I was thinking about how to remember the difference between the ligaments and the tendons. I don't know what.
Yeah, that's it. Leg bone, ligament. So bone to bone is ligament, muscle to bone is tendon.
Yeah, I know my brain is gonna. It does that. I don't know why, and I know the difference between, but
For me, I like the cook, so I think of the tenderloin. That's straight, muscle. Obviously, it's an underused muscle. That's why it's very tender, but it's a muscle. So muscle to bone, tenderloin.
That works. I like food, so that works. Yeah, that'll work. Makes sense in my brain. I have moments. Um, Cartilage consists of fibers of collagen. Now, cartilage is hard to regenerate because it does not have a blood supply like muscles. Can you take supplements once you reach a certain age and your body stops producing as much collagen? Yes. How effective it is subjective. There's no FDA proof definitively that you can ingest external sources of collagen to stimulate cartilage production. Can you attempt it? Yes. Do we do this on a regular basis? Well, some people, without realizing they do it because their body needs it, yes. You seen those people that will chew the gristle off a chicken bone when they're eating chicken? That is your body's attempt to get collagen from external sources. Some people do it as a habit. Sometimes your body's craving it. Sometimes it tastes good because it tastes like chicken, just crunchy. Now, your bone density decreases after the age of 35. Yay. This is why a lot of people shrink. They may be one height when they're younger, and as they get older, it's like they get smaller because their bone density is much thinner than it used to be. And this is why a lot of people have osteoporosis. It makes it easier for them to fracture bones because the bones are thinner and weaker. There are medications, I forget the name, it's a prescription medication now. It used to be very expensive that helped with osteoporosis. They have a lot of them on the market now compared to what they used to have. I will find the name of that medication because it is the benchmark and let you know what it is. Now, women that have a higher predisposition for osteoporosis, more so than men, and white women more than women of color. You're looking, but I'm not sure if which way she actually go.
Allegedly it's a mix, but I think it's the previous.
Don't know. Don't know the genetic makeup, so I can't absolutely say. But I will say this because I have learned this over time. People of a heterogeneous ethnic mix, people that are of a heterogeneous ethnic mix, is more than one thing. Sometimes, depending on which genes they have that are expressed, is what you may have to deal with more genetically as far as medical issues than the other. Hopefully not. If that's the case, that could be both of us. It just, yeah, I'm good. My family's good and confused. It just depends on which part of the genetic makeup is expressed in your genes. And there are some people that may not appear so, but they may have osteoporosis because they have more of a Caucasian gene makeup. It's been medically proven for whatever reason, white females have osteoporosis at a higher rate than Black women, Hispanic women, and Asian women. I don't know. Yes, it's it's definitely cultural, but it has to have a genetic quality. So that's what makes me wonder. Um, that is something to potentially research, see if there's anything that can be found on it. It will be interesting to know.
Itchy.
Just
Feel with some oil to
scratch.
them.
I'm not going there. Musculoskeletal injuries may result from either blunt or penetrating trauma or both. And it says on here, pathological fractures occur when medical conditions cause the bone to become abnormally weak. We were talking about that as far as the osteogenesis imperfecta. Um, that is a genetic reason that people can have weak bones and have non-traumatic fractures. Now, it depends on what causes the fracture. If it's a direct blow, which, yes, a bat to the leg or a steel pipe to your legs or your knees, yes, that's a direct blow. Indirect forces, if you were thrown around, secondary in the back of the truck and you broke something. Twisting forces, because people just are goopy like that. Or high energy forces, where you were struck by another vehicle potentially. Now, direct blow is where it's going to break where it was hit. That's where you would expect the fracture to be. It wouldn't be necessarily above or below it. It's going to be where you were hit. Impalement is what it says. You were stabbed through with something, be it a knife that's embedded, a piece of rebar, a table leg, because you were in WrestleMania or something. I don't know. Or it could be an indirect injury that occurs when force is applied to one region of the body but causes injury somewhere else. So that it would be more like you getting hit in the back and now your stomach hurts. Because maybe that blow to your back put enough pressure and it cavitated part of your bowel and it ruptured. I don't know. As far as an indirect injury, it may not be anything we can do about that. But in being impaled, we can stabilize and transport. A direct blow, we can splint and transport. Now, you would need to call for ALS intercept to give them something for pain, given that it is not part of the scope of practice for an advanced EMT to administer pain medications. Is that going to change? Very possibly. Is it going to change right now? No, because the state of Georgia just expanded the scope for all levels. Now, a person falling on an outstretched hand may have one or more injuries. Now, y'all weren't here that day. I forget older lady's name. She works around in Barber. She's an instructor there. Tripped on the rug outside of Student Success near cosmetology. Fell, braced both hands. No, but she did fracture both her wrists.
Nice.
The only one she actually noticed hurting was her left wrist, and it was splinted. Thankfully, she did not dislocate anything else, but she could have. Everything from the wrist up, and potentially fracture everything from the wrist up. Now, she did have a nice size chicken egg on her forehead. But other than that, she was in pretty good spirits. Thankfully, she did not hit her head. Okay. But as of right now, Sister Girl is not going to be cutting any hair anytime soon. Yeah, the flick of the wrist is done for right now. Now, twisting forces can cause injury, can cause a strain, sprain, and potentially a fracture, depending on the level of twisting that you are doing. And both of those look extremely painful. Okay. The top one is an open fracture, which we can see the bone sticking out. So there's no question if that's a fracture. And we can see the skin, the fascia, the subacute fat. Looks real tasty. And a closed fracture, which is the bottom one, well, it actually looks more like a dislocation because it's like the ankle is not in its proper joint with the tibia, but the skin is intact. The question is going to be on both of these if they still have pulses and motor function. So we have to make sure we assess for that on both. Now I'm wondering which one could be a compound fracture. So it depends. What some people call compound fractures are typically open fractures, but usually it's more complicated than a simple fracture. Angulation. This can be exciting and gross and fun all at the same time. I'll see if I can find y'all some pictures of angulations. It's when the bone is misaligned as a result of an injury between two fractured fragments. You may have seen, I think it was a soccer player that got kicked and his leg was twisted at like a right angle. Yeah, that hurts. Was and my question was his kneecap dislocated or was it
I'm not sure because his foot was the same, like kind of, he was a little bit outward, but his whole.
ooh,
Yeah.
ooh.
Yeah, definitely.
Yeah, that was not, he was having a bad day.
No pain until about 17, honestly.
I am not seeing what I want. Let's see if maybe on the video side. It's a distal fracture. All right.
Every time I see Herschel Walker speaking, I wonder, what is he lying about now?
Is this really who we want representing Georgia?
Did he really think that we wouldn't figure out the truth?
I don't think Herschel Walker is ready to represent Georgia, and I certainly don't think he's ready to represent me and my family.
6 players who suffered horrific leg breaks. Luke Shaw. Having joined
Hopefully it will
Manchester
show
United
the
in
actual
2014, Shaw was having a great start to his second season at Old Trafford, starting every league game under Louis van Gaal. However, his fantastic start of the campaign came to an end on the 15th of September in a Champions League match against PSV. Shaw sustained a double leg fracture following a challenge from Hector Moreno, ruling him out for the rest of the season and missing the chance to play for England at Euro 2016. Shaw would return to first-team action in the Community Shield final 11 months after suffering the injury. Djibril Cissé. It's hard enough breaking your leg once,
Okay.
but Cissé suffered that horrible fate twice. The first incident came in
Okay, this is not
2004,
showing what I'm
breaking his
expecting.
tibia and
It's
fibula.
just describing the players. I was hoping to be able to see the actual fractures. This may show it.
Match day 2 of the 1981-1982 season. Werder Bremen host Arminia Bielefeld, and 20 minutes into the game, Ebert Lienen is fouled by Norbert Siegmann. The Bremen defender is booked, and the Bielefeld attacker screams with pain. Lienen has a 10-inch wound on his thigh, with his bone exposed.
Oh, I'm sorry.
Germany is shocked. Lienen sees Bremen manager Otto Rehagel as the instigator of the foul.
Ich unterstelle ihm natürlich in keiner Weise, dass er gewollt hat, dass ein derartiges Foul dabei herauskommt, aber ich glaube, dass mir alle
Yeah, you can
Leute,
see the bone sticking
No
out.
way am I saying that he wanted this type of foul to happen, but I do think that everyone who saw the incident close up can confirm that he was encouraged to be more aggressive with this foul. His gesture was unmistakable, and what he said was equally clear. In that sense, I cannot help but blame the Werder Bremen manager for a deliberate request to commit a foul.
Trainer der Werderaner vorsätzliche Aufforderung zum Foulspiel vorzuwerfen.
Mr. Rehagel never gave me a signal. The foul happened in the first 20 minutes of the game, and during that time I had no contact with him.
The grisliest foul in the history of the Bundesliga had left its mark.
Es ist in erster Linie nicht so,
A number of defenders don't just want to play the ball. Some of them enter into a challenge knowing that the risk of injuring their opponent is high and try to get a sporting advantage through unfair play.
durch unfaires Spiel auszugleichen.
Ich meine, mir bleibt nur eins übrig, entweder ich spiele weiter und mache
Either I can carry on and play my game.
That's some gully shit.
Yeah, soccer is a very dangerous sport. Football, period. Let's see. This may be a good, it may show it.
Says September 1997, and Roy Keane bursting into the penalty area and had a flick at Haaland, and he did his knee ligament, and that was the year that Arsenal went on to win the championship.
Oh, Roy Keane on Haaland. David Ellery has a record of dismissing Roy Keane from the field of play. It's a red card issued by David Ellery to Manchester United's captain for the 4th time.
Who didn't quite show the one I was looking for, but you get the gist. Now, a simple fracture is a non-displaced fracture. That's usually what we are understanding. It's like a hairline. It's just a crack in the bone. Now you have different types of fractures. You got your transverse, which goes across, your oblique, which is kind of like an angle, your spiral, that's like a curlicue, comminuted, a multiple fracture, your green stick, which is like a fraying of the edges, an incomplete, and a pathological, and an aphesial. Yeah, this is a good picture of a deformity. Not really sure what caused it, but we can tell that is definitely in the tibia or the fibula rather. Yeah. Usually fractures are shortened and externally rotated. Usually, not to say it won't be internally rotated, depending on which way which that one looks kind of like it's kind of rotated. The toes are rotated out. They're externally rotated. Where it looks like the heel is kind of more kind of internal rotated, if that makes sense. It says usually the visual inspection will reveal swelling. You'll be able to see the change in the shape. It may not be that big. It depends. Now this looks, they say this is a fracture, but hell, some people's feet swell like this, so that might be a little hard to tell. Usually it'll be discolored though, if it's blood. It infiltrates the area. Some people take, the bruising is kind of subtle. It may take a couple of days for it to really discolor, which is kind of hard to see on this picture. It has a greenish, purplish hue to it. Now, typically a fractured bone, the area is going to be tender to palpation, any kind of pressure, whether you're standing, sitting, movement, is going to be tender. Most people are going to guard it. They're not going to let you touch it. Or if you do, you have to make sure you let them know, look, I just need to see what it feels like. Not that I'm going to mush it, poke it or prod it, even though you may want to. You have to refrain. I see it on your face.
Mine.
Yes.
Me of all people in this room. Not her, me. You shouldn't be?
No.
Wow.
Because she's not going to be able to handle it. You might enjoy it a little bit.
They're always in the funniest position.
Katari might enjoy it a little bit too. Not as much because he's going to be thinking about his children. His little children. He a football daddy. Okay. Now.
I'm a stepdaddy. Does that count?
Yes. Now, you may feel crepitus over the site, depending on location and how many bones have been pulverized or have been splintered in that area. Just because you feel some kind of mobility does not mean it's the actual joint that's moving. So if you have to compare, you can compare it to the limb that is not jacked up, to give you a frame of reference. There's a good open fracture that looks extremely painful. It is kind of hard to tell if that is the end of fibula or if that is a tarsal. It might be the heel. It's kind of hard to tell. I'm guessing because of the rounded end. But I doubt they're going to be able to move that. If they move anything, it may be the toes. And then that might hurt though. A bone can be dislocated in the joint. Some people can do it at will for certain joints. Sometimes you don't have any control over it. So sometimes if y'all see me wiggling, it's because my hip has decided to slightly dislocate when it feels like it. Nice. Yeah, it hurts. Nice. Yeah. But usually you can kind of slide it back in. You just look kind of special doing it. Depending on the level of dislocation is whether or not some people can reduce it and get it back in position. Like right now, I think I have a mild dislocation of my left shoulder, which I need to get x-rayed to make sure it gets put back where it's supposed to be. Because once it is dislocated, you can't necessarily, you won't have the range of motion that you had previously with that joint. Oh, that sounded like it felt good. Okay, in a subluxation, which is a partial dislocation of a joint. A lot of times people that are having whiplash have subluxations in their cervical and or thoracic spine from car accidents. So that's usually what the chiropractor is adjusting. And it's sometimes hard to see those on x-ray unless you are highly trained for that. Now, dislocations can have marked deformity. That's if they're a true dislocation. And a full dislocation, it can be swollen, it's going to be deformed, it's going to be painful, it's going to be tender, and virtual loss of normal mobility in that joint. They say it could be locked. They may have a little bit of movement. It's going to hurt. Circulation can be impaired. And these are what they're describing on here is a real dislocation. You would look at it and you'd be like, yeah, that's dislocated. It wouldn't be a question if it was a partial or not. You'd be able to look and see, yeah, that ain't right. It is an urgent injury because they can lose range of motion and circulation. Okay. Depending on how it's dislocated, it could sever some nerves, or at the least, it can stretch some nerves unnecessarily, or the ligaments or tendons, and cause future injury, which is not good, which could make them prone to other dislocations because that ligament is stretched beyond what it should be. Now, strains and sprains, they're tender, they swell, they sometimes are bruised, and usually you don't want to move that area. One thing that gets sprained a lot is ankles.
Tell me about it.
Y'all are such a loving couple.
Yep, I'm not home. I got some feelings. Anyway.
Instability of the joint is indicated by caused by increased motion. So the more you move it, the worse it gets. Now, strains happen to the muscle or tendons. So it's more of a muscle to bone type thing versus with the sprains, it's more of bone to bone issues. Okay. Physiologically, they are going to feel the same. They are going to hurt like crazy. You're going to do the raise, ice, compress, elevate. Rest, ice, compress, and elevate. Now, an Achilles tendon rupture. These are not going to be walking. They are going to be booted, and they're going to have surgery because that leg is no longer any good. Okay, they'll feel the pain from the heel to the calf, and they will not be able to flex their foot. If they have an amputation, it is not a good day. Okay, that's when it becomes separated from your body. You may or may not be bleeding out actively. There will be blood somewhere. Okay. Once you experience one, your life will be forever changed. Okay. Somebody's not having a good day. I'm wondering what was the circumstances behind this amputation. So it just depends. We need to, depending on the situation, if it is amputated or dislocated or broken, the golden hour from the time of injury to treatment is important for the preservation of the limb, nerves, and level of use. Okay, so we need to get them to a level 1 trauma center that has an orthopedic surgeon and potentially a vascular surgeon as soon as possible. Common sense should say at this point, because we keep going through this, make sure you're seen as safe. If it is not safe, it is not safe for you, let alone the patient. If you are not safe, you cannot help the patient. So everything else does not matter if you are not safe. Try to identify the mechanism of injury if possible. You may have to do some scene investigation of your own to figure out what happened. Depending on the scene, make sure you preserve as much of the crime scene as possible, letting PD know where you have or have not tread. So your shoe prints may not be part of evidence. Okay. Focus on your patient's mental status. Try to keep them as calm as possible. The calmer they are, the less blood they are going to lose. In the case of open fractures, barring an arterial laceration. Okay. If it's venous, it'll be a little bit easier to control as far as the bleeding goes. Identify the injuries and try not to hurt them any further. Now, that being said, if you're going to have to splint that limb, there is nothing we can do to make it not hurt. Even in the presence of pain medication, it's going to, it's just the level of pain that they are going to feel. What sadistic one? It's like you were somewhere else in your head just now. Okay. Apply tourniquets as needed, especially if it's an open fracture. It says address your exsanguination hemorrhage first. If they are bleeding, and it absolutely, if it is arterial, that is a life threat. We address that first. Then we worry about everything else. Then we worry about splinting after we have controlled the bleeding. Because if they stop bleeding, it depends. They may have the Pac-Man sounds. Okay. They can do boop, boop, and that's it. When they blink out of existence. So if we can control the bleeding, we will be good to go. We can keep them on this side of the dirt. Your pulses. At this point, you can provide fluids to help keep their blood pressure at least 90, depending on how much blood they have already lost. Okay. Now, that is not to say that we cannot hemodilute them by giving them too much fluids. Exactly. Okay. Now, Rulon has been going for a moment, so we are going to take a break. So she's been here since the beginning. Y'all just got here. So we're going to pause things for right now and take a 10-minute break.